So good afternoon, everyone in Ethiopia, and good morning for everyone here in the US again. And welcome to the wrap-up session, one of the two sessions we're going to have to wrap up what we have been talking about the last 2.5 weeks. We have the presenters back in two groups to kind of wrap the themes that we discussed and also provide you, the audience, the opportunity to ask questions. And I'm sure there are probably new questions that may have come up since we last met. I know Dr. Tewodros is also on the line. So Dr. Tewodros, you can maybe put your video up if you can. The panelists today are basically the initial group of presenters, where, as you remember, we started with the introduction and giving some background on day one, and that was done jointly by Dr. Tewodros and Dr. Elias. We had Dr. Rahel Selassie, who talked to us about airway management and infection control. We had, at some point during the course of the presentations, Dr. Siraj presented us with the preparedness part and also a little bit more deep diving into the pathology itself. And last but not least, the heart complications were covered by Dr. Henock. So I just maybe want to get started with the initial part from the introduction part. And what I was hoping to achieve today was for each presenter maybe to spend 5 minutes or so to summarize, their presentation from the last time, and also if there's anything new that has transpired since then, since the last presentation, to update us on that. So, Tewodros, I'll just go to you, and let's start with maybe you updating us what you see on the ground. How has it been since we started these conversations, particularly at your hospital, if there's anything new, as well as anything you may want to update us about. So I would start with you, if Malaku can unmute you to be the presenter. There you go.
Okay. So this is to summarize what I have presented last time, and my talk was on the burden of COVID-19 in Ethiopia and its response from the Federal Ministry of Health and the government of Ethiopia, and also the health societies, professional societies. And what happened after my presentation is that just when I presented 2 weeks ago, the number of patients who were diagnosed with COVID-19 were like 35. But as of yesterday, it was 112. So it has it is more than tripled in 2 weeks' time. So whatever measure we are taking, like since the first case in March 13, the government has started to take action on starting from the third day, like closing of schools, and also prohibiting gatherings, and also football matches, and subsequently, actually, a lot of actions were taken, and one of the best measures were quarantining people who are coming from outside Ethiopia, which I think has worked very well, since most of the patients, most of the cases that are diagnosed are those who have been quarantined. So despite all these measures, but the number of cases has quadrupled, tripled at least in the last two weeks, 1 week. So I think what I suggest is that probably, even though we didn't very well confirm widespread community transmission, but there is a possibility because we didn't do extensive blood testing, extensive nasopharyngeal testing or any serological testing. So probably this problem is increasing, and I think we need to be a little bit stringent because the social distancing, the people are not complying, with the social distancing as it was expected. And as of yesterday, actually, the government has put in place another action. Okay, so the government has put in place another action, that is cars are half of the cars are allowed to just for one day, and the rest the next day, even number, they divided by even and odd number. I don't know, that may also reduce people that are seen in the street. So probably we may need more stringent action, because such social distancing and some social actions measures may be effective only if 80% of the people comply to the measures, and that's not actually happening in Addis Ababa, and the rest of probably some regions are doing it. So probably we may need to bring in effect a more stringent measures to control the disease. That's what I have. Thank you.
Great, thank you very much. And I will go to Dr. Dawd from here, because I know Dawd, you have been really on a daily basis in contact, and also you have the pulse on what is going on at the higher level as well. Maybe this is a good time to hear from you a little bit about, I think giving the perspective also what we have here may make sense. So if you can just sum up a little bit from that perspective, both from Ethiopia and here, and see where we are and compare, and if there is anything that we have learned, at least in Wisconsin.
Thank you, Dr. Girma, Dr. Tewodros, and everybody. Dr. Tewodros started with this information that the Ethiopian cases are increasing. It's very interesting that the cases have increased or tripled. A number of reasons for that, one of them being we are increasing testing, obviously. But still, a lot of discussion can be made whether Ethiopia has already entered in the phase of that logarithmic growth, even though that growth looks like that is the case. I don't think that is the case for me. And I'll tell you why. Because the reason is, just imagine, for example, that there is a country, X country, and it increased, for example, its flight to entry to its own country by triple or by quadruple, let's say, just for an example. And you caught 1,000 more patients at the airport before they are introduced into the system, and you just took them out. It doesn't mean that the sudden increment of numbers has triggered an epidemic. Because for an epidemic to start, those cases have to be in the community and triggering second generation and third generation cases. Up to now, I didn't see that. Of course, all this has to be taken with a big grain of salt, because we know how fragile our system is. It just needs one or two mistakes. So be vigilant, of course, but still I am hopeful that there is no community transmission today, even though we have increased the numbers, because all of them are being picked up as early as possible, strengthen our system. That's the most important thing. So with that as a background, because Tewodros has said that, let me tell you a little bit of what I think, because my talk was on leadership and how you really can step up at this day and moment, because this is a very critical time. We are preparing and witnessing to really be involved in the interventions of what a pandemic is. This is the first time for all of us, and this will be a historic time. This will be the greatest story of our career and our life, honestly. So we have to internalize this when we are really being involved. If you are busy, things like that, really it's understandable. This is different, okay? Do not miss this opportunity. Be involved in the leadership capacity to respond wherever you might be. No one knows how much as you do. We think that we don't know a whole lot, but compare yourself with the politicians and decision makers. You are way, way away from them. So your input will be really critical in for the final outcome. I know how difficult it is in Ethiopia to be involved. People don't involve you very easily, don't appreciate your knowledge and internalize you in the system of decision making, but push yourself. This is big. Just don't be waiting for someone to call you. Pick up the phone, call them, ask them, tell them what your expertise is, tell them what you know, be involved, be forceful, and eventually they probably will look how important you are. Whether it's in Addis or in the regions, there has to be a decision command. The country, regions, a lot of people are confused as to what to do, when to shut down, when to ease, when to slow down, when to open once it is shut down, what would happen with the economy. These are all questions that all of us have doubts. No one has a magic answer. That's why it's very, very difficult. But be bold. Advise based on available data. When you summarize the data that is available and you give an advice, it doesn't mean it is correct, but you got to give it. Don't be afraid. Don't be wishy-washy. Don't be in between, because decisions have to be made at the day of pandemics. When you are entering into a pandemic phase and you're making decisions with the knowledge that you might be mistaken, don't be afraid to give the best available scientific recommendation, because somebody has to do it. But be ready also to revise your advice when the real data emerges, like what we are doing in America. Every day, Dr. Fauci and the others, they're revising all those models. But the reason is because real data is coming. But they are not shying away what they expect for the next week also. They might be wrong, but that has to be done. Try to understand what community transmission means, what the epidemics means. It's not only the numbers. As I told you, for example, today, if Ethiopia record 100 cases in one single day, but there are 2 in Tigray, 5 in Wollo, 7 in Amhara region, 20 in another one, 5 in this one. Does that mean a pandemic? If you only see on the numbers, yes, but it is not, because pandemics have to incubate within the community. I mean, what is happening in Wallaga has nothing to do with what is happening in Afar. So try to really understand how the pandemic's mechanism works. If you are really confused, try to collect data on pneumonia, on admissions to ICU hospitals, even if you can, morgues also. But obviously, most importantly, we have to increase testing. But you have to understand, if you don't have the pandemic phase, increasing testing is meaningless. I mean, if you are testing people who don't have symptoms, who don't have contact with a known case, I mean, you will be testing thousands and thousands of cases, but you're going to remain zero because the risk is not there. Until you reach into a pandemic phase, this exponential increment of testing is not to your advantage. Actually, you will finish your testing kits in a very short period of time. And when the real thing hits you, you will not have the testing kits. The biggest thing that has to be done right now is issues about contact tracing, isolation, quarantine. What is being done in Ethiopia regarding quarantine is really good. What is more scary for me nowadays is the border between Ethiopia and Djibouti. Because Djibouti, for me, has gone into the exponential phase. That's what it looks like when it happens. And when that happens and when it's out of their control, with the connection that we have with Djibouti, I think now at this day, Djibouti poses more hazard, more risk to Ethiopia than any other risk that is there for us. So this is really the thing that we have to work on. The other thing that we have to work on as a leadership is really work on PPEs. That is going to be the shortcoming of any hospital in this intervention. we need to make sure that each health facility have enough PPE for healthcare workers. So if you are in a leadership position, assign a single person who is going to be on a daily basis tracking what you have to fight with Ministry of Health, to fight with donors, have the inventory of your PPE, and also look at the guidelines that are coming out from every corner and try to kind of create your own guidelines on how you're going to use those PPEs when the time comes, how to reuse them, how to recycle them, how to autoclave them, and this kind of things. So really there are a number of issues. I will leave that all to question and answer, but I will stop with this. We are in it together. There is so much unknown about this disease. So far, my feeling is so good, but knowing Ethiopia, things can change in a very single minute, and we have to work hard. Thank you.
Thank you, Dr. Dawd. I think we'll go later to the question and answer session, but just to summarize what you just said and what Dr. Tewodros said, you are a little bit cautiously optimistic when Dr. Tewodros is a little bit cautiously pessimistic. And I know the audience are, here are picking up on that, and clearly being cautiously optimistic is a good thing where depending on where you are. And so I think there are some concerns. You can think about this. There are some concerns from some of our participants here that being, even cautiously optimistic may have in our setting a negative outcome in terms of people's attitude changes and stuff like that. So I will come back to you later, Dr. Dawd, to really elaborate a little bit. And I know we are talking here at a higher level. We're not really talking to the mass media. So, but still, I think the tone, we need to be, a little bit more optimistic or pessimistic is an important question people want to discuss. Next, I would like to go to Dr. Henock, who I see is ready. And we, as you all remember, he gave us some real thoughtful talk about cardiac complications. And he did dive a little bit more into the arrhythmia world. And let's hear from him, summarizing a little bit the discussion points and staying pertinent to COVID and arrhythmias probably and heart failure, I think.
Okay, good morning, everybody. Good afternoon, actually, for the people in Ethiopia. So basically, as you know, cardiovascular disease plays at both ends of the COVID disease. If you have cardiovascular disease, there is increased risk of mortality. If you have hypertension, all those underlying diseases that we talked about. So about 7% of the COVID patients, they have myocardial injury, especially the critically ill, it goes up to 22%. And we talked about the mechanism of the virus entry to the cell because it uses the angiotensin converting enzyme receptor 2. As you know, in cardiovascular disease, the RAS system, the renin angiotensin aldosterone system, is the mechanism whereby the angiotensin 2 acts on the receptors to cause vasoconstriction, fibrosis, and so on. But this receptor, the other receptor, goes at the other end. It produces angiotensin 1 to 7 that causes the opposite effect of the angiotensin that we know. So there was a lot of controversy about the ACE inhibitors and ARBs, whether they increase the risk or reduce the illness. But so far, there is no concrete data to suggest one way or the other. And we talked about the different presentations of in cardiovascular disease COVID. Mainly it's myocarditis, and the mechanism is it could be direct myocardial injury or cytokine storm. or it could be also microvascular disease. Having said that, there is increased biomarkers, cardiac biomarkers in patients with COVID who are sick, especially the troponin, the BNP, the D-dimers, and so on. In patients, they can have different types of EKG changes, ST elevation and ST depression, all different presentations. So even the ST elevations, it could be pericarditis, it could be myocarditis, or it could be, the traditional acute coronary syndrome. The one paper that's out in the last couple of days, I think it was yesterday, from the Sharma group in New York. They collected about 18 patients. It's on the New England Journal of Medicine. So these are patients, 18 patients with ST elevation. And half of them actually, they end up doing a CAT, and half of them, they did echocardiogram. And most of the patients who had ST elevation MI, they didn't have significant obstructive disease. Among the patients who they did the heart CAT, about 70% of them, they end up putting it in stent. Having said that, if you see the mortality, patients who had the ST elevation with COVID, it was about 70 to 75%. So this is very, very fatal disease in patients with cardiovascular disease. Even patients who doesn't have cardiovascular disease, they can develop cardiovascular disease, myocarditis because of COVID. And those patients also have high mortality and morbidity. And finally, we talked about the arrhythmia, on the West, this talk of QT prolongation on chloroquine, hydroxychloroquine. As you know, chloroquine is like staple food in some parts of Ethiopia, actually. I used to work in the western part of Ethiopia in Humara, so we give a lot of chloroquine to patients. But the home take message is patients who has baseline QT prolongation, we have to be careful giving them chloroquine, because it can induce QT prolongation in what we call it torsade or polymorphic VT. And there are dozens of medications that can prolong QT other than the chloroquine. I mentioned on my slide, you can see it. And a combination of those medicines sometimes could be fatal. In the treatment of COVID, even though we don't have any randomized trial support, treatment of chloroquine, but the combination of chloroquine and Zithromax is kind of the protocol we are using here. And both those drugs can prolong QT and they can cause torsade. I think with that, I will end up here, and on the question answer session, I may come back.
Thank you, Henock, and I'll now turn to Dr. Rahel to tell us a little bit more, summarize maybe her presentation from last time, and if there are some new additions to her thoughts, this is the time to share that.
Hi, okay, good afternoon, Ethiopia. The last time I was speaking, it was mostly about infection control and airway management, which is still very important even today. It's going to be important throughout the entire course of the COVID crisis. We talked at the beginning of my presentation about how it's transmitted, and we do know it's transmitted by contact and with respiratory droplets. And we talked about this coughing, sneezing, having contact with droplets if those droplets are on viable surfaces. And also during aerosolizing procedures. Something that's kind of a little bit newer since we spoke last is there is data out there that even talks about how some of this patient-to-patient transmission can even occur through speaking. So this just lends itself right into the next topic in the discussion I gave, which is about infection control. And for the general public, I think about it more like a source control. We have to make sure we keep social distance. That's probably one of the best public measures that can be done. 1 meter distance, about 6 feet. is what is recommended. And making sure people really try to stay home has really worked for us. Here, I live in Houston, Texas. Houston is one of the cities that did a stay-at-home order, one of the first cities in Texas, and we haven't seen as big of a or quick as a peak as before. So if the message can be clear to the public to stay home and to socially distance, I think those are two very impactful things. A third thing would be if anybody does feel ill or sick, they don't need to run to the hospital, but they need to stay home and self-quarantine themselves for 14 days if they're exhibiting those symptoms that we know about, which are like fever and cough and sore throat or muscle soreness and things like that. So after we deal with the general population, I'd like to take it down into the hospital setting, facility risk, and the hospital infection control. And when we talk about that, really what comes up here is hand hygiene, of course, making sure that the environment is clean, making sure that anybody who is admitted or anybody in the entrance is aware and conscientious about respiratory etiquette, which would be making sure if you do cough, it's in an elbow or sneeze. But since my last presentation, also some new things have come about. We have instituted a messaging to our public here in the United States that one of the best things to do, which we call source control, which is trying to avoid the transmission of the disease from patients who don't have symptoms or people who don't have symptoms. And so the public measure that's been given to the United States, which I think is very, very good advice for Ethiopia as well, is just to have everybody, no matter what, no matter if they're at the hospital, if they're at the grocery store, at home, whatever, just to always be wearing some type of a cloth mask. And if you think about that, that really will help reduce transmission, especially from a person who doesn't know they have the infection, transmitting it by speaking to somebody else. So I did kind of mention this last time, but it's become a little bit more generally accepted here for sure in the United States. And I really would like to really point that out, that if even whether you're taking care of a COVID patient or not, whether you're out in public or not, put a face mask. And that should be for all general public places. In the hospital, we talked about a couple of things that can be done. First of all would be triage, which is really important. Having, one set entrance where everybody is quickly triaged and you're being able to identify and then isolate anybody who is coming in with concerning symptoms for COVID. Making sure that you limit all entry points is important. We don't want to have multiple entry points. Just having one, maybe having a separate one for people with those symptoms would also be a good idea, because you'll separate them from people who don't have symptoms. The other thing, of course, would be hygiene in the hospital, making sure the same hygiene measures you want for the public are also done in the hospital. And then when you're isolating these symptomatic patients, of course, making sure you're doing all the precautions for contact and droplet transmission, which means you have to have healthcare workers there and you have to protect them. Give them the proper PPE and have a dedicated team to limit the exposure of all of your healthcare workers. If you have a dedicated team that you somehow rotate out, you can conserve your PPE and also, like I said, minimize exposure to other healthcare staff. Make sure, even in those isolated areas, that distance is kept between patients if you can, and also, of course, between healthcare workers and the patients. In addition to having a dedicated team, I think another very important thing is making sure you have a dedicated equipment for these patients. We don't want stethoscopes, blood pressure cuffs, pulse oximeters, or things like that being somehow taken from a COVID section onto a part of the hospital where you're taking care of patients who don't have symptoms. And then finally, I really talked about airway management, which is really my thing. That's what I do. I'm an anesthesiologist. But really the importance here with airway management is that there are things that are considered aerosol generating procedures. And if you think about it, if the virus is transmitted by respiratory droplets, anything that could possibly aerosolize those droplets puts anybody in close proximity at risk. So let's talk about what kind of procedures those are. We talk about airway, intubating and extubating patients. Mask ventilating patients can also aerosolize respiratory droplets, suctioning. Some of these non-invasive ventilation techniques can. Definitely CPR could. Tracheotomy, tracheostomy, any type of ear, nose, and throat procedure, all of those things could definitely aerosolize these droplets. And we don't want anybody who is around these procedures being unnecessarily exposed. So I think the biggest point is, if you're going to do an aerosolized procedure, recognize that it's high risk for the people that are performing the procedure. Make sure they have an N95 mask. We know when people are taking care of COVID patients, not everybody needs an N95, but if we have enough supply, it would be good. But if not, it's okay. A medical mask is fine. But during the aerosolizing procedures, it's extremely high risk. And so anybody performing an intubation or extubation, anybody mask ventilating, which we don't want to be done, anybody suctioning for these patients should be donning full PPE with an N95 mask. Minimize the number of people in the room when those procedures are occurring. And like I said, really protect those healthcare workers. Have the most experienced person. If a patient starts to decompensate badly and is in full respiratory distress, it's very important to make that one intubation with that procedure a success. And so we ask and recommend that it be the most experienced person with airway management doing it. And then during the intubating process, one of the things that is very highly recommended is that you do a rapid sequence induction, which is kind of different from what we would normally do for patients. Usually we oxygenate and then we'll mask the patient. But that, since we know will help aerosolize those droplets, we're asking to do a rapid sequence induction, which means avoid mask ventilating. Once you give the induction agent drugs, you just go ahead and intubate without any ventilation. And really the biggest message for my talk was really for everybody to stay safe. Use your clinical judgment, because that's going to always take precedence, and it doesn't replace any of these recommendations. Protect the patients, protect the healthcare workers, protect yourself. And that's it.
Well, thank you, Rahel. I mean, this was really very clear, nicely summarized. We covered almost everything you talked about the last time, which is perfect. Which is perfect. So I know Dr. Elias is in the middle of his ICU work, and I'm not sure if he's able to join us, but as soon as he can, he will. In the meantime, I think we have, nice pointers that have been already started. It's hard to summarize everything, but I think if I may, just take a stab at summarizing a little bit of a few of the things that have been said. It looks like there is a little bit worry that there is indeed this ongoing trend of increasing the number of cases. Probably the fact that they have tripled over the past 3 weeks has been really worrisome from Dr. Tewodros' perspective, although he acknowledges that there have been really a lot of measures that the government has taken that seem to be appropriate and timely and have been taken with some vigor. However, there is also a lot of issue around social distancing, particularly because our society is really not responding to that as they should. We heard also from Dr. Dawd a little bit about the epidemiological aspect of things, and with a little bit more optimistic view about this. And I think his point is probably clarified in such a way that he thinks things are really controlled so far, and he is actually happy about it. And the fact that they have, they have been doing significant amount of contact tracing and quarantining and limiting people coming from abroad seem to be working relatively well. And although he agrees about testing, he thinks that just doing testing is not really, at the end of the day, the solution for everything that comes with COVID. And that said, there was a very important message that I just want to also actually amplify, which is really, we are all here as healthcare professionals. We should consider ourselves leaders because we know more, we can do more. And so Dr. Dawd's message was very clear. We just need to be involved. We have to actually model the way. We have to show that we are washing our hands. We have to show that we are wearing whatever mask we have. And we have to talk to our parents, relatives, friends, and make sure this is a pandemic. And this is indeed a very dangerous thing, and it can wipe out populations easily. It has happened in the past, and if we don't pay attention, it can happen again. So I think putting a little bit of a fear factor is not a bad idea, although that's not what we want to do, but it's really important, at least us as healthcare professionals know what is coming, and we have also the power, at least in our environments, to tell our students, to talk to our residents if we are faculty members, and if we are faculty members, to talk to other faculty members, and if we are leaders in the universities and hospitals, to really take it up the chain of command. And also going downwards in our communities, in our societies, wherever we live. And it's really, really important to think about others. And this is not the time to think about only yourself, because only with ourselves we cannot live in this world. We need others to live well. And so it's really important for the healthcare professionals, therefore, as Dawd was saying, that we need to be aggressively be involved, and we need to be leaders by modeling the way, making that hand washing or sanitizing or covering our faces or our nose and mouth, and also calling on people who are not doing it, even within the hospital itself. So I think being involved and being part of the leadership is a very, very important recommendation, and we cannot be seeing this as from a sideline like any other individual in the country. And so I think that message should be very strongly discussed again. I know Dr. Henock went back to talk to you about the angiotensin receptor issues. He talked about the medication-related arrhythmias that can cause problems, the myocarditis, that is really a big issue. And last but not least, the newest evidence in terms of cardiac cath for ST elevation MIs, where there were a lot of negatives, but clearly high mortality when they have ST elevation MI, with or without cath at this point. And so the prognosis there becomes terrible. I think Rahel's messaging about hospital was in the bigger picture of triaging these patients when they come, making sure you have an area and space that is limited in terms of access, making sure you control crowd, that not everybody gets into the hospital from everywhere and you don't know how that's the easy way to transmit and actually have a lot of disaster within the hospital. So controlling the hospital entrances and triaging appropriately, limiting the area of entry. And she really emphasized a lot on all the procedures that may lead to aerosolization, be it bag masking or trying to intubate or extubate. All these things to be really carefully managed by a team that knows what they are doing. And in fact, having an airway strike team for this kind of patient may not be a bad idea. And this has to be done with the utmost precautions in terms of personal protective equipment. So that probably summarizes a little bit what they have said. And of course, with questions and answers, we can go a little bit more deeper. And I just want to give this opportunity first for both Dr. Dawd and Dr. Tewodros, so to say, the optimist and the pessimist, a little bit to elaborate, because there are some of our, attendees are asking, hey, this is a country with only 400 ventilators, and there is no reason to be optimistic here. We have, quadrupled, and people are not showing the social behavior that we expect from them. And so it looks like at least those who have messaged here are really pessimistic. So So Dawd, can you just go back a little bit?
Yes.
Maybe the word optimistic is not the right word, but maybe you want to really elaborate a little.
Yes, you put a word in my mouth. I didn't say I'm optimistic. So let me correct it so everybody will hear me very clearly. Okay, I'm not optimistic. We are not different than any part of the world. We are going to have a pandemic and we are going to suffer because we don't have the resources. But what we have to know is what we communicate with the layperson and what we communicate as scientists should not be the same. If you hear all what I'm saying in mass medias, I am the most pessimistic person. I am scaring people because the community transmission is going to happen. People are not staying far away. And our society's lifestyle and financial and economic background does not even allow sometimes to have that kind of distance. So I am pessimistic on that regard. It is going to happen. We're not different. Pandemic. The question is it right now happening or is it going to be in the future? But these are scientists we have to discuss, because otherwise if just only fear is guiding our decision, we're not going to make a rational decision. Because we're going to make lockdowns, this, that, without any substantive evidence. And then we tire the system and the economy. And when the real thing happens and hits us, people are not going to be with us. This is the message, okay? So let me go one by one, what I mean. We have to look at the data. We have to make sense out of the data that is coming because we have to plan based on the data. Fear cannot guide us to make a decision of a data. So for example, it is better for now in Ethiopia to spend all our energy and effort to just quadruple, quintuple, whatever it is, the contact tracing capacity, so that when that pandemic just hits us, really, where we don't have arguments about me, whatever, then we would react at that time. But if we are just spending the energy on lockdown of a city who has not seen a single case, we are spending our very precious resource in a place where it should not be. Case in, for example, all schools are closed throughout Ethiopia. I mean, Wallagga might not have seen a single case. Arba Minch might not have seen a single case. That's what I'm saying. So you spare them right now with cautious things like face masking, distancing, this. When the real thing comes in, you ask the people to do more. That is what the whole message of mine is. Because we have to dampen the curve. We are not going to depend on ICU. We're not going to depend on our ventilator because we know our capacity. So we have to really start strategizing the best way to address. But again, I am very pessimistic. The mistake that has been done in Afar right now in the last 2 weeks, because our border was porous, might have already done the pandemics. So this is what I'm saying. So don't take the wrong message, please. But as a scientist, this really we have to discuss. By the way, tomorrow, there is Thursday at Ethiopian 3 p.m. there is a webinar about how the modeling works, and if you're interested, you can come there and we can discuss this.
So one thing that I didn't want to say, you are optimist. I just say optimistic opinion. So I just want to be also corrected. So that's it. Dr. Tewodros, is there anything you want to add based on the conversation?
Girma.
Yes. Can I give Dr. Tewodros just a moment to kind of, I just want to find that balance between the two and then we go further.
Okay, thank you, Dr. Girma. And also, I think I was also misquoted. Probably it's not a pessimistic idea or pessimism, but what I wanted to say is that there is a definite increment, and I have also mentioned that most of these cases are from the quarantined people. But still, that we shouldn't forget that there are a number of patients who are diagnosed as positive for COVID they didn't have any contact that they could trace. So probably, even though it's not in a wider community transmission, but there is some sort of sporadic or cluster transmission going on because people were identified in some regions, like it can be in Oromia or in Amhara region or southern region of the country, where they went there without being noticed. And there are people who have escaped from the quarantine, who paid money for probably for the policeman or something like that. And this is happening now and then. And probably, as Dawd also said, that there might have been some wider transmission to the countryside or to the regions. So that's worrying me. Otherwise, as it has been mentioned, most of the cases either they had travel history or they have contact history. So just probably, even though most of our cases are imported cases, but there is a chance that we can have, local transmission going on. So, what I suggested is that probably, I'm not suggesting lockdown, but probably we may need to strengthen the social distancing because people are not, they are not implementing it. So probably, as Dawd said, we have to, we have to implement what is necessary for an action, or what is necessary to control the disease status currently. So thank you.
Henock, any additional thoughts or questions?
Actually, it was a question for both of them, for Dawd and Tewodros. I agree with Dawd. We have to scare the people, especially the policymakers. We got to put all our resources on prevention. But I am also cautiously optimistic and here are my questions. So my question is, do you think, can you hear me?
Yeah.
My video is, okay. So my question is, do you think the virus is a different strain in Ethiopia than in the West? One. The second thing is it less contagious? Because there is what they call it RO in epidemiological term. What I understood was the regular flu, the RO, the rate of transmission, one person infects 2 or 3. But for this virus in the West, the RO is 6. Is the rate of transmission, or is it less contagious in Ethiopia? The reason I am saying is, even though we don't have testing, if there is disease, it would have overwhelmed, the healthcare system. We could have seen all these patients in ARs and hospitals. That's why I am saying I am cautiously optimistic. Either it's a different strain of virus, either it's less virulent because of the environment, or the behavior of the virus is different, or it's less contagious. So can you comment on that?
Yes, Dawd?
For me, it boils down to a simple thing. We don't have a lot of information, so we cannot assume that the virus is different. For my purpose, I take them the same. The virus is the same, the ultraviolet rays, the BCGs, all those issues later on, we will study them. But at this time, we don't have enough evidence. But I also ask the same questions that Henock asks, and I come to a different explanations. So the RO, by the way, Henock, for flu, it is around 1, but for this disease, it's around 3. Okay, in Ethiopia, it might be 4 or 5 when it gets in. We don't know once until the epidemic starts. But the biggest thing for me, the big difference has been when the disease is circling, it starts actually with the countries who are much more connected with the world. I mean, as much as we are so proud of our Ethiopian Airlines, how big it is and things like that, if you see the registry of how many people gets into a country versus, for example, US or in European countries, Ethiopian Airlines or exposure to foreign countries is smaller than one of a very average city in US. And there are like 200 cities bigger than that city. when there is 10,000 or 20,000 people coming to this country in a day, maybe that might be 3 months worth of exposure. So US has been, the entry was the biggest thing for me, I think, because we don't have a lot of exposure to foreign countries. And once you stop that one, the number of people who are getting in and trying to fuel the epidemics are very few. So it is going to happen. I have no, I mean, I don't have a doubt if you ask me to give a scientific opinion that it will happen. It might be slow. We might be very late, 2 months from now down the road, so that we will learn so many things in between, but it will happen. It is not because of the virus, but it is because we had less exposure to foreign new arrival of new cases. Exactly, look at Djibouti. Djibouti has so much access to foreign countries. So many new cases have been percolating. They didn't know about it. All of a sudden it bursts like a dam. Now it looks like they're almost out of control measures. Thank you.
So one question goes to Rahel. I don't know, Rahel, are you on? So Rahel, the question that comes in, your opinion and your thoughts about makeshift hospitals and ICUs. Do you think the standards in those kind of, makeshift environments could be such to protect the healthcare professionals? What do you know? What is happening around you? And it's really from both care for the patient as well as, protection of the healthcare workers' perspective. Any
so was I being asked if it should be different?
Yeah, if you think the standards could be adequate enough, do you think, that is a reasonable alternative to open these huge complexes where patients can be held and also, ICUs are created at times to take care of this patient? Would standards be really met to take care of them appropriately?
Appropriately.
I don't know if
Okay,
you guys
so
have. I don't know if you have a similar experience in Houston or not. But.
So we've increased capacity in hospitals. We haven't had to make shift, but we've changed certain hospitals with numerous floors now are just completely dedicated for COVID patients, so that they're separated, but they're not in a separate area. We don't have a whole hospital dedicated to it. It depends on the number of patients you have, and it depends honestly a lot on resources. I do strongly believe the standards should be met in whether it's a makeshift or not. And I personally think having a separate makeshift hospital where COVID patients are there is safest, in my opinion, because they're just removed and it's easy. Then it's very clear who the dedicated team is that would be there. Not a lot of increased chance of transmission or exposure for other patients. So I do like the idea. We haven't had to do it here, like I said, because of our capacity. We have a lot of hospitals. But I know, for example, Germa, you told me in your city they have an entire hospital that's just dedicated for COVID patients. I actually think that's the safest because they're separate, and isolating is part of infection control. Yeah,
so that was going to happen in tier 2, but it did not happen because the number so far has been really relatively low. So that's it. There is an yes.
I'm sorry, this is Elias. I need to go. So I just want to say a couple of things before I go. Sorry. No, I joined you guys halfway, I think. Unfortunately, my unit is crazy. So, no, the only thing I want to say is that it was a great discussion from both sides, and I think it was successful. But one thing I want to point out to everybody here is, I think I know Dawd mentioned that when we talk to a layperson and among ourselves, we got to use a different language, which I completely agree. I think the same is true when we talk to the policymakers too. Because I don't know our role, because unfortunately we are trusted, and we should be. So, and our voice means bigger. So I think we have to show them the worst case scenario, because if we assume we have a little more than 100 in Ethiopia, and we're talking about probably undetected 5,000 easy. So with epi language. So I think we have to show them that part as well. But I like the discussion though. Both of you guys make a great point, Tewodros and Dawd. But I just want to point that out too. And that's what
in terms of one maybe last question that is coming that can really have a lot of epidemiological education for all of us is, I may want to hear from Dawd and whoever is willing to talk about this is, say, there's a patient in Juma that was found in the community where she lived for a month and she was found to have COVID. And so what are the next public health measures that needs to happen to really protect the expansion of this problem? So this was a question by one of our listeners.
So this is a great issue, and it will happen more often as we go down the epidemic time zone. So I don't know a whole lot about this case, so I cannot give a specific recommendations. But if I was advising Juma right now, the first thing is contact tracing. That is the most important thing. Go wherever she has been. As much as possible, contact us and has to be isolated and quarantined, because that is where it is going to start. The second generation of cases is not the worrisome one. The second generation, you will know them because they are going to tell you, oh, I know her, or I have seen her, or we have been at the same place. The third generation is a bothersome because they have no clue about where they got it, because they have been removed from their first index case. So that is the first thing. The second thing is, as a country, we have to adapt a system of isolated lockdowns. So if this case, for example, it takes 2 weeks by the way. So I'm watching this Juma case. If they have done a good contact tracing, 2 weeks from now, we might see 2 or 3 new cases, but that is it. That is the success story, okay? But if you're going to see exact right logarithmic growth on that area, the next thing is lock down that area. That is a mistake we have done in US. If we have locked down Seattle, we would have been enjoying our nice weather here in Wisconsin. We have waited for 6 months to get out of snow, and now we are sitting in our house, as you can see us, because we made that mistake. We didn't lock down when we first see it. So when I say all those things to loosen or not to loosen, when it is right, you have to be harsh. We don't have any other option in Ethiopia. So I think in about 7 to 10 days from now, if they start to see more cases in Juma, not in Juma in the whole, this is in Limu from what I read. So for you have to identify the area and lock it down. But if she has been traveling to so many places, that is what makes it very difficult.
So one additional question about testing, and I know there is so many different test kits, and people want to know, number one, how quickly does a PCR test become positive? And then just overall specificity and sensitivity of all the tests that are out there right now. If you guys can summarize, particularly Dawd, maybe you know more about them. If you can summarize, about the tests. Just
briefly, again, the test becomes much more sensitive when people are symptomatic. So that's why one of the challenges of indiscriminate testing becomes a problem, because they are in the lower phase and the viral load is very low. So the sensitivity is low. But if somebody has a symptom, the sensitivity is actually, remember this one, more than 90%, but it depends on how you take the swab. Because of that, the average sensitivity has been around 70%. Because, I mean, if you see how you have to take the swab, it is really invasive procedure. So that is the biggest thing. In terms of false, the specificity is very good, more than 90%. So what it means is, if it tells you it is negative, then it is negative.
Probably next time when we talk, there might be some changes, because I think there are also studies that are happening comparing actually all the different tests that are available, and that might be a lot more clearer next time. So from infectious control perspective, Rahel, do you think, COVID testing needs its own lab? Is it something that is being done in the same lab environment? What are the risks of contamination? I don't know what you guys are doing at your hospital. And Dawd, what are we doing in our hospital? Are we separating the labs that do the testing? And you guys, any comments on that?
For our testing, so first of all, everybody who's testing has full PPE on all the way, just 100%. I don't know if I've said that before, but anybody doing testing has full PPE with an N95. And then in the lab setting, it's the same for the people handling the samples, I guess the pathology samples. I don't think it's done in a separate area. I think they just wear the protection, but that's just, I'm not sure because I don't really work in there. Dawd, I'll let you answer.
Yeah, you're right. Actually, this question was asked last week also when I was presenting, and I said they are doing it in the same lab because they were doing it in the early days, but I didn't know how it is going on right now. So I went to the lab actually the same day to figure out. So they are doing it exactly the same thing. So what they are saying is two rationales, which are that makes sense because I talked to the head of the lab at that time. What he said is basically there are so many patients who are suspected whom we don't know about COVID. So if we're going to say COVID and non-COVID, we're going to expose falsely a lot of medical professionals because they would be thinking that they are working on a non-COVID environment. And that was one of the reasons for a decision. The second thing is you don't know how much this is going to be. So if it is so big, I mean, it would overwhelm any system, the small system that you created for this testing purpose. So for that reason, everyone in the lab is acting as if they are working in a COVID environment and the testing place is the same place.
So I think we have really covered a lot of the topics, and Dr. Tewodros, so for the next week seminar, I think the team will reach out to you just to make sure, you know, some of the items are pertinent and are coordinated in such a way, the participation. You know, I know in Addis, probably with you being there and others in critical care, there's a lot of education that happens, but I think the seminar might help a lot of the general practitioners that are dealing with some critical care issues. So that's what the team has in mind. So they will, you know, reach out to you as they are putting the table of content, if you will, together. So do you have any last comments on what has been said so far before we close? And I don't know if Dr. Wondosen is there, but I don't see him. If he's there, he can also make a comment. Or
I think
Dr.
Dr. Wondosen should make a comment. We completely forgot if he is there.
No, I didn't see him. I'm not sure if he is in there. If he is, please go ahead. But Dr. Tewodros, if you have any closing comments.
I have no much things to say. I think it was really a wonderful discussion. So it's good that you arranged this closing event, and I think we'll have one on Thursday. That was really good for us to summarize what we have been discussing the last 2 weeks. Thank you so much, for the EADG, the Ethio-American Doctors Group. Thank you very much. It has been very, very helpful to our physicians, to our residents, and we are using, some of the slides you shared us for teaching. We have a scheduled training for the whole staff of the college as of tomorrow. So we are getting ready for that. And this training for the last weeks has been very much helpful. We are updating our knowledge, we are reading. Thank you so much.
Yeah, no, great. And just feel free to also have, as the talks are going to be online, just feel free to direct people to go and also listen to those. But you're right, it makes a lot more sense to get a set of slide decks of your own that you can maybe, share with your, and of course, all the talks and slides are to be shared without any problem. So with that, we'll stop here and we'll continue to communicate and send you some more information. And most importantly, we are looking forward to actually creating ongoing online seminars and discussions, even in the post-COVID area, because there's a lot of topics that can be covered, and we are just stuck in one topic, but there is a lot of additional things, be it from infectious disease perspective, from endocrine perspective, from surgery perspective, from anesthesia perspective. I mean, there's so many things we can really pick and discuss on a regular basis without making it every day, but at least if we think about twice a week, it's something we can all do, and we are working towards putting together a plan for that purpose. So for today, I thank everybody for participating, and I appreciate the presenters being here today early in the morning and sharing your thoughts and knowledge. So, so see you next time. Have a great day.